I think we'll go ahead and get started. And then if Miranda, if anyone joins while we are presenting, just go ahead and let them in. I am Rhonda Swellmeyer. I will be presenting for you today. This meeting is recorded, and we will have the opportunity for the slide deck to be available to you after the call. We are going to be talking about promoting interoperability, specifically around 2025 today. However, we will be going forward with some really awesome viewpoints on 2026. A little introduction here, KONZA Health. In case any of you may have noticed, we have rebranded from KONZA National Network to KONZA Health to better reflect the influence that we have in the healthcare industry. Today's focus, we will be talking about obviously promoting interoperability, what it is, how it's operationalized, the 2025 promoting interoperability requirements. You'll note here for eligible hospitals and eligible clinicians. We'll talk a little about best practices around how to have a successful promoting interoperability program. And then we're going to look ahead at the 2026 changes. Most of those are proposed at this point and not finalized. And then I'm going to review some of our resources that I use for this presentation and pretty much in everyday practice, so that you'll have those handy for yourselves. And then we will open it up for questions. A lot of you on this call may already know who I am, but I am a nurse and I am the Health IT Workflow Specialist here at KONZA Health. I work with our organizations to utilize the technologies available to them from KONZA and to have success in better outcomes, better payment initiatives, and in providing measurable results. For those of you who aren't as familiar with KONZA, we are also known in the Kansas sphere as KHEN, but we did transition to KONZA National Network, and now we are KONZA Health because we go beyond just connecting organizations and data. We actually do a lot more in the space of providing analytics tools, actionable insights, and of course, data sharing. We're a private nonprofit provider-led organization, and one of the most probably relevant things for the folks on this call is we are also a designated qualified health information network as of December 2023. That means that we are one of, I think, around 9 or 10 of in the nation who are designated under TEFCA to exchange data in a national network under the Trusted Exchange and framework. This just highlights as well our reach across the nation, not just within our QHIN, but also our health information exchanges. So we do provide regional and state health information exchange in the states highlighted here. So let's go over our Promoting Interoperability program. Some of you on this call may be very familiar with this. Some of you may have fallen into this by necessity, but just as a refresher, Promoting Interoperability was actually launched in 2011 as a result of the American Recovery and Reinvestment Act of 2008 that established the HITECH Act and essentially became what we know or knew as meaningful use. That was the program incentivized to have hospitals and clinics who were participants with CMS to implement electronic health records and to use them in a meaningful way. As we transitioned from that implementation of electronic health records, the program itself was renamed in 2018 to emphasize interoperability and patient access to health data. So instead of the focus being on the electronic health record and implementation of that, now we want to take that data and we want to make it interoperable, and we want that data to speak across systems. So really the goal is to encourage the use of those certified EHR technologies to improve upon and to optimize interoperability, not just for clinicians, but also for patients to have access to their own records. So how is this operationalized? The reason why I want to talk about this is because promoting interoperability is a concept that is not exactly the same in the payment programs where it's operationalized. So for example, with eligible hospitals, we have the inpatient prospective payment system. So that'd be your critical access hospitals, acute care hospitals, organizations that participate in CMS. Then we also have eligible clinicians. Those used to be our eligible professionals. So sometimes I interchange those. But that is our quality payment program that was established under MACRA. And that includes promoting interoperability as a part of a MIPS or APM payment program. So for hospitals, we're looking at, it's totally known as Promoting Interoperability Program. If you're looking at clinicians, like a physician practice, and if you're on the call, please go ahead and make sure you're muted. Since we're using Teams, we don't have everybody muted. What we see there is that the Promoting Interoperability is a portion of the MIPS program. So those kind of, to me, are the same, are the main differences, although generally the requirements are the same for the promoting interoperability part. So let's talk a little bit about the 2025 promoting interoperability requirements, just because I think it's important to understand what we should be doing now. I think one of the challenges that folks have is that we may not see all of the finalized information, or we may not plan ahead for the next year. So, in 2025, you really want to be looking at the information in it basically now, or this time last year. But to show you the overview of what's required, what we've done is compared the inpatient promoting and the IPBS promoting interoperability programs, so the hospitals on one side and the clinics on the other, with their QPP MIPS promoting interoperability category. So both must use the KONZA Health IT certification technology. It used to be 2015 cert, but last year that terminology was changed to just say KONZA Health IT certification without that year. Both have a minimum 180-day continuous period. So if you have not started or have been ready to begin your attestation period by July 5th, you may be going to struggle with having a complete attestation. So it's always important to know that you have everything in place by July 5th at the very latest to get a 180-day continuous attestation period. To submit the data, I grabbed the dates here. As we all know, these are subject to change quite often. Things happen. We have natural disasters, or there's technology issues, and those dates are subject to change. So always keep your eye out on that. But right now, hospitals will be attesting by March 2nd, and clinics will need to have their attestations in by March 31st. They both have two different websites. If you're new to the inpatient reporting program, you need to make sure you have your logins through HARP to be able to get into the HQR secure portal. So, and that's definitely something you want to start earlier rather than later, because it does take a while to get your validations to get those logins. The payment adjustments typically for each calendar year are going to be incurred 2 years later. So it's not we scored this in 25 and now we get paid this in 26. It's a 2-year lag behind. Those payment adjustments can be penalties, they can be neutral, and they can be incentives. So when we see here is our minimums to avoid penalty. For hospitals, you have 105 points possible. I think 5 of those are bonus points. It's all or nothing. You either get 70 points or higher, or you are under 70 points, and then you get a negative payment adjustment. That can be a significant amount of money, especially if you're a critical access hospital. And that could be a few $100,000 that you may miss out on. For our clinicians, for our QPP and MIPS eligible clinicians, there's 100 points possible, and it works a little differently. If you're under 75 points, so 74 and under, you're going to get a negative adjustment. I think that could be up to 9%, negative 9%, so that can be pretty significant. 75 points, you're going to have a neutral adjustment. That just means you get to stay the same, which is not always a bad thing, but with inflation and increased cost, etc., you may always want to strive for over 75 points or 76 points and above so you can get a positive adjustment. Right. So to talk a little bit about what the hospitals require, I am going to focus on what we support and what we know here at KONZA in your Promoting Interoperability program. So as you see here, there's e-prescribe, there's 4 areas. There's e-prescribe, there's health information exchange, which we are going to focus on. There's provider to patient exchange, which we also help support. And then there's the public health and clinical data exchange, which has really taken on an increased focus since COVID. Electronic prescribing, PDMP, we don't have any sort of involvement with that. But with health information exchange, you have one of 3 ways that you can attest to that. One is 2 separate measures that require a numerator and denominator. That's going to be the one sending the support of electronic referral loops by sending health information, which is worth 15 points. And then the second half of that measure is supporting those electronic referral loops by receiving and reconciling. So that tends to be the challenge. It's not so hard to send your information to an HIE or transition of care via a secure direct message, but it seems to be more of a challenge, especially for our smaller critical access hospitals that aren't transferring acute care patients in that fall into that denominator. To get that information and get a continuity of care document, you may know them as transitions of care or a visit summary, etc., and then reconciling that health information. It used to be you only had to do one chart or one patient. You'll need to refer to your electronic health record to see how they are figuring your denominator and your numerator to ensure that you are doing that reconciliation in a way that is capturable and will populate to your Promoting Interoperability attestation reports. The second measure that you can use is the health information exchange bidirectional exchange. That's a 30-point yes, no. That doesn't go into a numerator and denominator. It just says you're doing it or you're not doing it. An example of that would be you're sending data to KHIN and you have a bidirectional interface or to KONZA that lets you pull that information back in. It's not separate sending and receiving. It typically works into the workflow. That is for our organizations who are part of our health information exchange that did not join our QHIN. So for the most part right now, you may not see a huge difference in how that works. But let's say if you're a hospital with Epic or an EHR that is a QHIN, that is a member or is a QHIN, you may have joined under that QHIN, but that doesn't mean you're not still part of our health information exchange because you may be engaged in our HIE at a more regional or state level. Regardless, as long as you are exchanging that information bidirectionally, then you can achieve those 30 points. The third, and this is the newest method for supporting health information exchange, and that is enabling exchange under TEFCA. So if you are a member of our QHIN, many of our organizations, especially in Kansas, are members of our QHIN and are also members of our HIE. You have those two ways that you're really working with us. It's typically more of a policy versus the technology. So under TEFCA, it's still worth 30 points. TEFCA is one of those things. It's one of those entities or that policy that is continually being developed and operationalized. So we do encourage that if you are integrated with us and you have not joined a QHIN, that you go ahead and join a QHIN, because that will get you in that foundation for national exchange. The next is the provider to patient exchange. We do provide a patient portal for organizations who have EHRs that perhaps don't have a patient portal, or there is some limitation to the availability of that. So regardless, if you patient that I remember, or I mentioned that we needed to have patient access, that was part of promoting interoperability. That's your patient portal. You need to ensure that you are absolutely providing the ability of patients to access their own records. That's worth 25 points. And then we run into the public health and clinical data exchange, which I think is probably one of the most challenging parts of this, because it has expanded so much since the pandemic. This is worth 25 points. You, at this point, need to be engaged in active engagement is required for those measures. So there's or being engaged in at least 2 of these: syndromic surveillance, immunization registry, electronic case reporting, electronic reportable lab report, or the ELR. And then you need to have a level of active engagement for the AU surveillance and the AR surveillance. They separated those 2 out. It used to be 1 measure, now it's 2. Some things to keep in mind, because this has been such a fluid evolution of data sharing with public health, and I will get into more of this when we look ahead for 2026, is that KONZA does help support this in a multitude of ways. I will talk a little bit more about this, but I do want to mention that for electronic case reporting, there is a proposed measure to suppress it for 2025, because the CDC has paused onboarding. As many of you may know, one of the big changes last year, I think for 2024, was that we could no longer stay in onboarding for eternity. You could have 1 year of onboarding, and then you needed to be in active engagement. So you only have 2 years to really get in line, and then to connect and test and go live. You've got those 2 years. With that being said, ECR, as I mentioned, is most likely going to be suppressed for 2025. I was on the most recent CMS QPP call, and there was a question asking, what does that mean to be suppressed? Basically, you'd still attest, but that attestation will be ignored. So you don't want to just put nothing there, because you won't get scored at all, and it won't suppress the measure. I know there'll be more information coming out about that, but I did put a link to the press release, and if you have more questions, feel free to reach out and I can get you more information on that. With that being said, and I will go into more of this again with how KONZA is supporting things, but if you are in Kansas, there is quite a bit of public health connectivity that we have provided for you with KDHE. You can see over here, and we're going to go into these requirements for 2025, but these are unscored, but they do require an attestation of yes, and that's your SAFER guide. And your security risk analysis. So those 2 tasks that need to be accomplished. I don't believe they have to be accomplished. I know the SAFER guide doesn't have to be accomplished during that 180 days. It can be done at any moment or any time in the year. And then the acting to limit or restrict the compatibility or interoperability of CERT. That is that information blocking rule that says if you're able to share data and you're choosing not to, then you are blocking information, and that is a no-no. There's some nuances, there's some exclusions, but it is going to be really important to know that if you have the ability to share CCDs to an HIE and you're choosing not to, or if you have the ability to send information via secure direct message to a referring provider and you're choosing not to do that, that can bring you trouble if there's a complaint made. And then there is the ONC direct review. I don't know how many organizations are doing that. It's an optional measure where, or it's not optional, but O&C, you basically say, yes, O&C, you're allowed to review our EHR to make sure that it is meeting the criteria for interoperability. The optional measures and requirements are going to be related to public health and clinical data exchange. You only have to report one for 5 bonus points. Generally, what I hear, you just want to make contact with your public health department and your HIE to see what's being sent. I know we do provide some support in that, especially around congenital abnormalities. We do provide some I-10 codes, or we do provide reporting for that. There's some other reportable conditions that we also provide to KDHE. And if you're curious about what that looks like, feel free to reach out. As far as eligible clinicians, it is almost exactly the same for eligible hospitals. That's why I spent a little more time on that. E-prescribe is you can see here all 4 of the PI measures for IPPS are also part of the promoting interoperability portion of QPP. So same thing with health information exchange. You have 3 options. If you're not sure which option you're using, please reach out to me, because I can help you identify that, because you really do need to know what you're doing so that you are able to validate that in case of an audit. Provider to patient exchange, same thing. Need to have a patient portal available. Public health and clinical data exchange, that one is a little less burdensome than the hospital because of ECR, and you're not doing AU and AR reporting. But you can see here, immunization registry reporting, that's a relatively new requirement in many states, because immunization reporting was not nearly as prolific with the clinics until COVID and COVID vaccinations. And then of course ECR, which I just mentioned, they're moving to suppress that measure for 2025. That's still not finalized yet, but they're looking at doing that. CMS is planning to do that for both IPPS and QPP payment programs. And then you do have the options to report that would give you those bonus points. That can be your public health registry, clinical data registry, or syndromic surveillance. So again, we do help support that, especially in Kansas. So if you are curious if that is something that you are reporting for, we would recommend you either reach out to us and then we can connect you with KDHE. The attestations are also the same. You'll see over here, they're really working at the CMS policy level to get our these things aligned, so that, if you are a hospital with clinics and with outpatient MIPS eligible clinicians, that you're not having to follow 2 vastly different promoting interoperability programs. So how does KONZA actually support your promoting interoperability program? First, through health information exchange, we talked about that, which is the data exchange to support all 3 options, including TEFCA, the patient portal access, and then we do provide validation certificates. Usually those will be sent out to our contact on file by February of the following year. So your performance year of 2025, we will send those certificates in February of 2026. For public health, we do support immunization registry integration. Some organizations, their EHR connects directly to an immunization registry. That's very common. Some organizations with EHRs that don't do that connect to us, and then we transport that data onto KDHE. For syndromic surveillance, we do automatically provide that registry information to KDHE. It is We work with them very closely to identify which ICD-10 codes they are wanting to monitor for. If those come to us, then we forward that information on. It's de-identified as needed. And then something that we do, I think, that is very different than our than other organizations is, even if we are not technically supporting you in providing information directly to your state health department or any other health public health entity, we do provide public health project management support. Chris Guerrero is our public health director, and she is amazing at making sure that we can connect you with the correct people, help facilitate those connections, and ensure that that you're compliant with those requirements. And then typically the validation certificates are provided by the state. That is because we may push that data, but they're the ones that are actually validating you. So the validation certificates, for example, if you are in Kansas and you're reporting to KDHE, you will get your validation certificates provided by the state, and they also do those after the first of the year typically. If you need a historical certificate, you can reach out to them too. If you're not sure who to reach out to me and I have that information. And then the third way we help support you is with information sharing and compliance. This is where we talk about information blocking, and if you've received those validation certificates from us in the past, this is that certificate that states that you have been sharing data with us. So this certificate is also mailed or emailed out with the health information exchange portion of Promoting Interoperability, and those are typically sent by February 2026. Something I do want to reiterate is don't wait until February to know if you actually did it. It's really important for you to double check, and we're going to go into this with best practice, but it's really important for you to know what you're attesting to before the end of the year, just so you know if there's anything specific you need to do to help, maybe things, your interface isn't working correctly, or you have concerns. It's very important not to wait until we send you a certificate to know if you passed or not. Because we are not saying you passed, we're saying the information came to us per the requirements. Then there's some other interoperability tools that we provide that help support other parts of promoting interoperability if you choose to use those. So for example, rapid alerts, that can be utilized to help identify patient care transitions, which can help you with your quality scores, can help you with quality initiatives that you may be involved in. HQ Insights is also our analytics dashboard where acute alerts live, but that HQ Insights will help provide insight into population health. And we are currently working on some very cool updates for that to help identify high-risk patients based on their risk scores. So I'm really excited about that. And then another way we help support you in your quality reporting and in any aspects of MIPS and IPPS is our DAB accreditation that we provide through NCQA. What does that do? It helps make your data shareable and interoperable so that your quality scores more accurately reflect the work you're doing. That I cannot emphasize enough how absolutely important that is. All right, so next we want to really dive into best practice for compliance. There's a lot of planning that goes involved in this, or that is involved in this, and I do have another slide deck available that I can send to you that has more detail about best practice, because we could really go into the weeds on this. But there's some categories of compliance actions that I recommend for organizations. And these are things that I did when I was part of, when I provided the attestations for my organizations. And these are things that I have identified as important, and when I'm working with organizations on ensuring their readiness. Even though KONZA provides technology for certain aspects of promoting interoperability, we're still here to help you because nothing operates in a vacuum, and we want to ensure that what you're doing with us is not affecting something else negatively, or that it actually is enhancing some of your other initiatives. So to start, technology readiness. It's a no-brainer. You have to use ONC or ASTP certified EHR technology. I've included the Chapel website search link here. That's where you go in and you look up your EHR and you can literally see what it is certified to do. I found a lot of things in my EHR that I didn't even know it was able to do because it wasn't built, or it wasn't, when we implemented. So I think it's really important to understand the capabilities of your EHR and what it's certified to do. So that link is there, and I think it's incredibly helpful. I go to that all the time. And then also know your vendor roadmap. They usually have customer groups, communications. It's quite frequent that I find out that a lot of organizations, or the folks in an organization, they're not receiving the updates like a newsletter, or they're not reading them, or it's going into their junk mail, because that's how the vendor is communicating with you what their roadmap looks like. And as we move from simple HL7 V2 and V3 interfacing to FHIR technology and APIs, it's going to be really important for you to understand what your EHR is capable of doing. Here in, I think it's 2027, we are going to really be seeing a lot more prior authorizations happening with FHIR directly into your EHR. So know your vendor roadmap. Also, know what your system is capable of in regarding to your supporting your PI, promoting interoperability objectives. So does it support PDMP integration? Does it support bidirectional capabilities for data exchange? So it's just understanding what your technology is and having it ready to support your goals. Second is data standardization. This is where some of you have probably gotten on those wonderful calls with us where we screenshot your EHR and make sure that that data is consistent with what is sent to us in a machine readable format. But what it boils down to is ensuring the use of consistent terminology and consistent structured data, such as SNOMED, LOINC, CPT, ICD-10, CVX. Those are all it's a bunch of alphabet soup that I'm explaining to you, but essentially there's a lot more translation codes beyond ICD-10 that are built into the backside of your computers, or should be, or backside of your EHRs. So is the right LOINC code associated with the lab test, so that some other system that receives that lab report can actually read it, because it cannot read hemoglobin. It's going to read the LOINC code affiliated with hemoglobin because it can't read that terminology. Making sure that your continuity of care documents or your patient summary, not the one necessarily that goes to your patient portal, but the one that you would generate to send to another clinician or to our HIE, what USCDI version is that? And is it complete? Is the information that's going into that document truly usable and relevant? So right now, I believe a lot of EHRs are still stuck on USCDI version 1, and we're already up to version 6 as a draft. So you really want to make sure that you're at least at version 2. If you don't know if you are, contact your EHR and ask them where you're at. You should be able to see it on the Chapel website as well. Next is workflow integration. This is a real challenge for a lot of organizations because you know what your promoting interoperability measures are. So for example, reconciliation of medications from a CCD that you've pulled in, or just reconciling that data. What happens is the PI measures that are being qualified or quantified may be falling outside the workflows that your staff has, that your clinicians have. So let's try, it's really important to say, oh no, you're going to have to go to this totally other different module to actually do this. Is that truly what we have to do? Let's fix the technology. Let's get it into our workflows. It takes a little bit of work, but your clinicians will be much happier and your scores will look a lot better. If you ever need help with that, please let me know, especially when it comes to reconciling those CCDs that come in or what the data looks like coming in, because if a clinician doesn't like the data, they're not going to use it. And it needs to be relevant. We want to ensure you're not just checking a box. This is where we want to ensure that the data is usable and that clinicians and patients benefit from it. We want you to build real-time data entry protocols and closed loop communication. What does that mean? What that means is if your provider is seeing a patient, kind of gone are the days where you could take 2 weeks, a month, 6 months for the provider to actually finish the clinic note or the ER note. We need to ensure that the workflows support real-time documentation as best as we can. Obviously, that's not going to happen in a code or in an emergency situation, but we really want to make sure that we are building those workflows out to capture the data that's needed in an intuitive workflow. And then obviously health information exchange, determine what you're already doing. I find that a lot of organizations, especially if they've had turnover, have no idea what their connectivity is with us and what we are and how we can help them. One of the best things I can also recommend is identifying your TEFCA readiness by onboarding to a QHIN. If you're not part of a QHIN, we can certainly show you more about that. Obviously, we are a QHIN. We would love for you to be part of ours. But if you're not part of ours, if you're part of a different, or you're looking for a different, whatever, we're happy to help you identify the resources to help you make a good, well-informed decision. Next is working on the security and privacy. What is really important here is understanding MFA, implementing multi-factor authentication, role-based access, which means not everybody needs to have access to everything within the EHR, depending on what they do. And then one thing that I think is sorely underestimated and underutilized are audits, especially audits of accessing outside records. So something I think is important is if you have bidirectional capabilities and you have people that are pulling in records from outside the organization, is that you are able to audit that information. You need to work with your EHR to find out how you can audit who accessed outside records. There's some pending litigation about that, so I think that is something you really need to focus on. And if you need more information about that, let me know. It's not us, obviously, that's having issues with, but patients want to know that you are making sure that only the people who need to see your data are seeing your data. Patient access enablement, making sure that information is available on demand. Implementing FHIR API, so not just for your own patient portal, but I'm seeing a lot more apps that are allowing that patients can allow to have access to their patient portal to pull in information. So staying on top of that, because you do not want to information block patients. If they have an app and they want to get that information, then you're going to have to make sure that's going to happen. And then monitoring. This is something that I think is probably also under recognized as a very important tool. That is understanding what in the world you're doing and what your staff's doing and how things are working. So we need to be looking at the technical capabilities. Are they working? One way you can do that is to simply log into our portal to see your own data. If you're not seeing your data there and you know you're supposed to be sending it to us, that should give you alarm bells. I know we at one point we used to send out a quarterly or even every 6 months to the client admin saying, hey, make sure your data looks good, make sure it's flowing, because we don't always know if something has happened on your side that's shutting something down. So log into the portal, make sure the data is there, look up 5 patients randomly from the previous month, make sure the information is there, and make sure the data that's in it is what you want in there. So if you need help on learning how to do that, let me know. I'm happy to assist you with that. Maintaining audit materials. When I say audit materials, I'm not talking about user audits. I'm talking about if you are audited. So CMS can choose to have a third party come and audit you for your attestation. I've been through that before. It's been a long time, but it is very, very stressful. Anything that you can show, and that includes just screenshots, that includes reports you're running out of your EHR, that includes the certificates that we provide you, put those in a network folder that not just you have access to, or not just one person, ensuring that you have an audit. We called it an audit book. Many moons ago, it was actually in a 3-ring binder at my organization. And then we put it into a network folder and anybody could access that, add information, etc. And if you want to learn more about that, let me know and I'll be happy to help. Run reports. Don't wait until the end of the year to make sure that your bidirectional capabilities actually worked, or that you actually somebody reconciled a report or reconciled a CCD. Make sure that you're monitoring this stuff. You should be monitoring it at least for the first 3 months of the calendar year, and then you can start your attestation period and then continue monitoring. And if you run into issues, you document that as a variance report, whatever your processes are. You would put that in your audit book and say, during this time to this time, our interface was down. Okay, that happens. You need to be able to justify and support what is going on with your measures and with your promoting interoperability technology. Something else that I think is super important is collaborating with your vendor. You talk to them, join their listservs, join their participation groups if they have them. They do provide information quite often on what's happening. They just may not put it right out in your face. So you have got to be proactive in understanding which measures are included with your EHR, especially if you're implementing a new one or there are updates, because not every EHR is going to come with every measure already built out. So for example, your ECQMs, your improvement activities, quality measures, what have you, every EHR isn't going to say, oh, we have all of those built. They're going to probably have a canned set of ones that are built out that are most common, but then they could probably build out others as well. So make sure you know which quality measures are included with your EHR build and which will have to be built out in addition to what you purchased. Sustainability planning. This is another pitfall that I see, is that there's not an internal roadmap and there's not resources allocated to this. It's almost like a lot of times promoting interoperability falls on the person who just said, fine, I'll do it. That person leaves and then there's a scramble to figure out, oh my gosh, we have to do this attestation and we don't even know what we're supposed to do. So you've got to have policies and procedures documented, and those are perfect for your audit book as well. How to create new logins for HARP, for QPP, what those resources look like, and then planning ahead. Are you going to have some capital investments for new technology? If so, that needs to be communicated during your budgetary processes. All right, so looking ahead for 2026, not a lot of changes. You can see here, the security risk assessment is just going to be bigger. So yes, you're still going to attest for the security risk analysis under the HIPAA security rule, but you're also going to have to attest to having conducted a security risk management assessment under the risk component of the HIPAA security rule. So there's going to be two in there. I need to do a little more deep dive on what exactly that entails, but just be aware there's going to be a second attestation, so you're going to need to do that. The high priority safer guide has been updated. So from the 2016 version in 2026, you'll be using the 2025. These are proposed again, but odds are these will be passed along unless there is feedback from participants that that's good. So understanding that there is going to be an updated safer guide, and I think there's 8 sections with that. The attestation period is not going to change. It's going to be a continuous 180-day period. They're hoping to kind of make that indefinite. But there was a caveat mentioned that they could identify, or they might decide to increase that depending on the need. They do recommend that you attest for longer than 180 days. And then the performance threshold, this is for hospitals, by the way. The performance threshold for hospitals is going to go from 70 points to 80. And they plan to continue that in subsequent years. But of course, they can always bump that up even higher. So you're going to need 80 out of 105 points. So those little bonus points can be very helpful. And then there is a new proposal, and this is just to build upon TEFCA and QHEN. So this is where public health data exchange is an optional bonus measure for public health reporting using TEFCA. Essentially, it would be your public health entity is a member of a QHEN, and you're a member of a QHEN, and that's how you're choosing to share your data. I don't have a lot of information on that yet as far as what that specifically looks like. And we are working with KDHE on that QHEN collaboration. So stay tuned for more information on that. As far as eligible clinicians, all the same, except the performance threshold is going to be the same. So 75 points is neutral payment adjustment, under 75 is going to be a penalty, and above 75 is going to be an incentive. Everything else here is exactly the same as it is for the hospitals. And then before we get into questions, I do like to point out our resources because I think it's very important. This is what I use, but I also think these are things that are incredibly helpful for our end users. Something, promoting interoperability programs, that's your hospital. I don't think that one's nearly as up to date. I don't keep it as up to date as the QPP one, but it is there, and it is helpful for, sending you to the listserv to get comments. There is a calendar year program requirements for hospitals infographic, and that's really where I took that data from. I love infographics because it breaks it down very, very specifically. We have the PI specs manual that tells you that what you actually need to do, like what will help you. What is the validation criteria for this, for these measures for the promoting interoperability, what exactly that looks like. Medicare promoting interoperability program from the CDC, that's just anything related to PI and public health reporting together. Then there is the cheat sheet that I found for the fiscal year 2026 inpatient prospective payment system proposed rule. That's where I got a lot of my information. And then we flip over to the clinicians, eligible clinicians, QPP, MIPS. The QPP website is really a great resource for all of you. I did want to mention, and I didn't before, that there are some practices who are exempted from the promoting interoperability portion category. Those are typically small practices. However, small practices can still attest under promoting interoperability, and then you get your points, which can help you, especially if you are struggling in another category like cost or under your ECQMs or improvement activities, that can help bump up your score so you can get those payments. So even if you're exempted from it, and promoting interoperability itself and sharing data and doing those things may still be worth it if it bumps your points up and you can get a positive payment adjustment. Also keep in mind, as part of MIPS, there's several different reporting channels. I'm not going to go into those, but be aware that traditional MIPS is what we're mostly used to, is going to be transitioned out, and most of our providers will be under an advanced payment model, which may also include an MVP, which is basically more specified. So APMs is based kind of on primary care, and then the MVPs are going to be your specialty program, your specialty providers like neurology, pulmonology, and so they're very much more targeted. Promoting interoperability is still a category, but just be aware that you'll be transitioning eventually in the next few years away from traditional MIPS. There is the resource library. This is incredible. I think it's a great tool. It also gives you, your timelines. And then I did include the link to the ECR onboarding pause so that you would have that verbiage when you're thinking about your ECR and how you want to handle that. And then I did include our TEFCA, not ours, but the RCE homepage. This is TEFCA. This is going to tell you everything you need to know about TEFCA and QHENS. This is a great resource for understanding. And then, of course, the Chapel search page. If you have questions about what's working, what's not, feel free to contact the help desk and they can direct you to the appropriate resource. You can also contact me directly. If you have specific public health questions, you can contact Chris here. She's amazing and she will assist you with any of the questions related to public health. So we are going to open
the chat.
Oh, we do have a question in the chat. Okay, that's what I was going to say, is we're going to open it up. That is a really great question. We are working on our FHIR capabilities. We've got a lot of really cool stuff coming down the pike. Quite often we do in our quarterly webinar, our leadership will talk about that roadmap. And then that webinar materials are available on our website. If you have specific questions that aren't answered by that material, feel free to reach out. Any other questions that anybody has? Okay, well, if you do think of something in the interim, feel free to shoot any of us an email that was on that contact list and we'll be happy to help. As always, we thank you for your time and participation with our organization. Thanks so much.